Okay, Dr. Shovik, we are live now. You can start.
Welcome to the expert crosstalk on Empagliflozin and a very good evening. The topic is multi-pronged, multifaceted and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor trial, does SGLT2 inhibitor may be considered as an important drug for HFrEF? For this, let me introduce today's speakers. Today's speakers are Dr. Thomas Alexander and Dr. Sridhar, and I will moderate Dr. Shovik. Dr. Sridhar is an associate professor, Department of Endocrinology and Metabolism at Madurai Medical College, and also a visiting consultant at Vadamalayan Hospital, Madurai, Tamil Nadu. Dr. Sridhar is a member of ESI, ITS, and also a treasurer in Endocrine Society of Tamil Nadu for 3 years, and he has 25 publication index journals, including JCM, JAPI, and IJM, and clinical endocrinology and endocrine practice, and also has been awarded as a best outgoing student in MD at JIPMA 2008 and ESI, TYSA, and AV Gandhi Award winner in 2012. I welcome Dr. Sridhar in this expert web talk.
Good evening.
Dr. Thomas. Thank you, sir. Our next speaker is Dr. Thomas Alexander. Dr. Thomas is the head of the Cardiology Kobai Medical Center and Hospital, Tamil Nadu, and also a founder, a trustee, or director at STEMI India, and also STEMI Care. He is also principal and co-investigator of various trials and also several national and international publications in this credit. And I welcome Dr. Thomas Alexander in this expert web talk, and I'm handing the session to Dr. Thomas to start with the presentation. Thank you.
Thank you, Dr. Shovik.
Thank you,
okay, okay. Let me first thank you for the invitation to be here on today's meeting. Basically, what I will walk you through is the role of empagliflozin in heart failure and the data that we have regarding that. Now, if you take the Framingham heart study and look at diabetics over a 30-year period and look at the cardiovascular complications that they have, whether it's coronary artery disease, cardiac failure, intermittent claudication, or stroke, you will see that the most common cardiovascular effect of long-term diabetes, whether it is in men or women, is cardiac failure. Now, if you look at many of the other outcome trials, which looked at MI, stroke, and death in diabetic patients, you will see again that heart failure is the most common outcome, much more common than MI, stroke, or cardiovascular mortality. So heart failure is clearly, in the diabetic population at least, is something that is very important and something that we need to keep in mind. Now, there's always a question when you look at diabetes, control of diabetes, and you look at intensive and less intensive control. We do know that the early effects of good control is in terms of microvascular complications of diabetes. The macrovascular complications are not that apparent. But if you look at the trials which looked at intensive versus less intensive, there seems to be a benefit in myocardial infarction. But when you look at heart failure, the fatal heart failure or admissions to hospital with heart failure, you can see that it didn't really make much of a difference whether there was an intensive control or a regular or your usual control. So clearly, merely controlling the blood sugars adequately is not going to reduce the heart failure incidence in the patients with diabetes. What about the drugs? Do they have an effect? And you can look at multiple drugs, whether it's metformin, sulfonylureas. Initially, tolbutamide was shown to increase cardiovascular mortality. But if you look, it was only once the glitazones were introduced, particularly rosiglitazone. This is somewhere in the 2007 time, when Steve Nissen from the American College of Cardiology did an analysis and showed that it actually increases mortality or heart failure. Now, subsequent meta-analysis may not have confirmed this, but really that was the first time that it was highlighted that once you are releasing new diabetic medications, it is important to see if they have a negative effect on cardiovascular morbidity or mortality. And this stands to reason because the commonest cause for mortality and morbidity in diabetic patients is clearly a cardiovascular complication. Now, the GLP-1 antagonist, DPP-4 agonists, GLP-1 agonists and the DPP-4 inhibitors, except in the SAVOR trial, there really didn't seem to be much of an effect in terms of heart failure until the SGLT2 inhibitors came to and the trials were looked at. Now, if you look at the early trial with empagliflozin, this is the EMPA-REG outcome trial. When they looked at it, and this was really because the FDA had mandated that at all trials should look at cardiovascular outcomes. So all trials that were looking at diabetic medications need to look at cardiovascular outcomes. So this outcome trial was looking at cardiovascular outcomes and death from any cause. And what they found was a signal to show that when you used SGLT2, particularly empagliflozin, in this particular trial, whether it was in terms of death from any cause, primary outcome, this is a 3-point maze, cardiovascular death or hospitalization for heart failure, all of them seem to show an improvement, in fact, with the use of empagliflozin. In fact, the heart failure reduction seemed to be really very significant. And this has been shown by other trials using the same class of drugs. EMPA-REG outcomes showed a 35% reduction in hospitalization for heart failure, a 38% cardiovascular death reduction, and a 39% improvement in kidney outcomes, and or reduction in deterioration in kidney outcomes. And all of this statistically being significant. And other trials, the CANVAS with canagliflozin, the declared TIMI-58 with dapagliflozin, all of them seem to show similar effects to varying degrees, that it seemed to have a positive impact both on the kidneys and in heart failure and in cardiovascular death to a larger or smaller effect. So clearly there was something going on, and this a drug which was initially brought in for diabetes, suddenly people began wondering whether this had a role apart from diabetes. And this is where the EMPEROR heart failure study. If you look at, this was published this year in NEJM, the cardiovascular and renal outcomes with empagliflozin in heart failure. Now, the EMPEROR trials have two parts to it. The preserved, which looks at heart failure with preserved EF, which is EF of more than 40%. That result should come out sometime next year. But the EMPEROR reduced is what we are talking about now. So basically, it included patients with EF of less than 40% with elevated NT-proBNP. And the cutoffs were different for different LV dysfunction levels, who were on guideline-directed heart failure management as was prevalent at that time, and it included everything: the AC inhibitors, ARBs, the ARNI, as well as beta blockers and mineralocorticoid receptor antagonists. So this is really the current recommendation in heart failure. And it's a multi-center, multinational trial across the globe. India was also part of this. And the endpoints, the primary endpoint was a composite of cardiovascular death or heart failure hospitalization. The first secondary endpoint was recurrent total or recurrent heart failure hospitalizations. And the second secondary endpoint was a decline in GFR. Now, these clearly are very important endpoints when you look at patients with diabetes. But interestingly, the EMPEROR was not purely a diabetic study. It did have a significant 50% odd patients with diabetes, but also had patients with heart failure without diabetes. So this was the study design. It was a 1:1 randomization, empagliflozin 10 milligrams, or matching placebo, and all patients received appropriate treatments for heart failure. So there was close to about 3,700 patients followed up for about 16 months, mean age of 67, and about 24% were women. The inclusion criteria: chronic heart failure, LVF less than 40%, or with a heart failure hospitalization within 12 months, and an elevated NT-proBNP. Now, the levels were different for different LV dysfunctions and for patients with AF. Excluded were patients with acute coronary syndrome, those with heart transplant, cardiomyopathy due to other reasons, severe valvular heart disease during the acute phase of decompensated heart failure, or those with a recent ICD or CRT. Importantly, I think it's good to know these things, that 18% were Asians. Across the globe, the patients were from Europe, North America, Asia, Latin America. Most patients were in NYHA class 2. So it's a clearly stable sort of heart failure was the population that was studied. Type 2 diabetes, 50%, so 50% were patients who did not have diabetes. GFR of normal GFRs. Medications, if you look at that, 48% of patients had GFR less than 60. So a significant number of them with renal dysfunction. So medications, you can see that a significant number of them, 90% had ACE inhibitors or ARBs. The valsartan sacubitril combination in about 19%, 71% with MRA, and 94% with beta blockers. You can see that 31% had ICD and CRT in 12%. So clearly, a very, very well treated group of patients that were getting this medication. So if you were to see a benefit in a group like this, clearly it's an add-on onto what is an optimal medical therapy that is already in place. And these were the principal effects. If you look at the primary outcome, which was cardiovascular death or heart failure hospitalization, it was 19.4% versus 24.7%. And you can see that very significant, the confidence interval of 0.65 to 0.86. This is on about a 16-month follow-up period. Cardiovascular death and heart failure hospitalization. Cardiovascular death was reduced, but not significantly. Heart failure hospitalization very significantly reduced, 13.2%. So mainly driven by heart failure is where you see the composite endpoint. Importantly, if you look at the primary endpoint, you can see that the separation is fairly early, and they continue to separate as they go down further weeks. If you look at the composite renal endpoints, you again see a significant hazard ratio of 0.5 with a confidence interval of 0.32 to 0.77. It's a very significant p-value there. If you were to then look to see NYHA function class deterioration or improvement, you can see that 20 to 40% very significant in both directions that you can see. And you can see that the effect was seen starting very early, within 28 days of starting a medication. As you saw in the earlier slide, you can see that the curves continue to separate. So significant early, and the improvement continues. So there was a primary endpoint at 25% reduction in risk. First secondary endpoint, which is heart failure hospitalization, a 30% reduction, and a slope of decline in GFR over time of 50% reduction in renal events. So very significant also. So the other important factor is that in the EMPA group, there was no intensification. In fact, there was less intensification of diuretic use. So really, they were getting better, and that's why you didn't need to intensify the diuretic use. I think as important as that is to understand that these results were irrespective of whether they were diabetic or non-diabetic. So across the board, I think there was improvement, and therefore you could very well say that its anti-diabetic effect is probably added feature of this rather than the primary effect. And the heart failure management is probably the main effect of heart failure or reduction in renal dysfunction. Now, how does all this come about? And there are multiple pathophysiological aspects that you could say. There is some amount of natriuresis. There's improved kidney function. The cardiorenal physiology clearly improves. There's both a reduced preload, afterload, and reduction in LV wall stress, and a reduction in interstitial edema. I won't go into the mechanism, but clearly there are multiple ways in which this does. How does it act on the heart directly? There is speculation on this, whether it's merely a shift to the ketone metabolism, which we know is more efficient in diabetics, especially those with heart failure. Is that the reason, or there are many other, whether it's the inhibition of sodium hydrogen exchange, which might be the basic reason, but that's various speculations. So where have we progressed in terms of heart failure treatment and looking at it? What is good for both treatment and prevention? We know that AC inhibitors, ARB, beta blockers, and exercise do them. What is the treatment for heart failure that's established? That's tRNA, evaporatin, CRT, ICD, and MRA. But therapies that could prevent heart failure or reduce the incidence of heart failure, clearly SGLT2 inhibitors today now has a place in this. What is its contribution to science and literature? I think in patients with symptomatic stable heart failure with reduced EF today, I think there is clear evidence to tell us that empagliflozin has a role irrespective of whether they are diabetics or not. Is this purely, is this a class effect? I would think yes, because we've seen similar data with dapagliflozin as well as empagliflozin. And this is a meta-analysis published in The Lancet, which suggests that both go in the same direction, though there are certain things which are slightly different, but it could be related to the cases that or the type of patients that were chosen for. So the benefits were seen whether patients had diabetes or not, were women or men, were younger or older, and were receiving neprilysin inhibitors or not. Such a combination of benefits is unique among available drugs for heart failure, and that's the editorial in The Lancet. So the results of this trial indicate that empagliflozin is superior to placebo in improving heart failure outcomes in stable symptomatic heart failure with reduced EF. The benefit is primarily driven by reduction in heart failure hospitalization. There was also a benefit in renal outcomes. And so I think this is an important trial and mirrors the finding of the DAPA heart failure trial with dapagliflozin. And therefore, I think this class of drugs is today going to be one of the drugs that is important in heart failure therapy. These are guidelines which talk about where does SGLT2 come in management actually of diabetes, and maybe Sridhar should discuss that more than me. But clearly after metformin, the other drug that one was almost first line today would be either a GLP-1 receptor agonist or SGLT2 inhibitor. Thank you for your attention. Dr. Shawik, I think you're muted. Maybe you should take over at this point.
Dr. Sridhar, you can start the presentation. Thank you, Dr. Thomas, for your wonderful presentation.
Yeah, just a minute. Hope my slide is visible and I am audible.
Yes,
Yeah.
sir. Yes.
Yeah. So good evening, one and all. At the outset, I would like to thank the Lupin team for this invitation. And a great pleasure to share the program with Dr. Thomas sir for this molecule regarding the empagliflozin, multi-pronged, multi-faceted, and multiple beneficial approach. And I will be discussing regarding the cardio, since cardiological topic already discussed by sir, I will be discussing regarding the endocrine as well as the diabetes perspective. And everyone well aware about the basic mechanisms how the SGLT2 inhibitors acts. So there are multiple agents available in the market to getting the glycemic control. And so the first and foremost may be the targeting the pancreas, maybe by sulfonylureas or by insulin, and subsequently the DPP4 inhibitors, and targeting the insulin resistance, the metformin or glitazone, and came to the pictures, and other molecules even though less commonly used. And the recent additions over the past 5 years, that is a gliflozin, SGLT2 inhibitors, that prevents the glucose absorptions in the proximal tubule of the kidney. And so the source of SGLT2 inhibitors is the bark of the apple tree, that is a fluorosin, hence the gliflozin has been termed. And so the published strength of evidence, you can see that almost the first research publications from the DEPA, and subsequently the remogliflozin, and subsequently the CANA and the EMPA. Even though it started late with the EMPA, almost currently more than 5,000 articles in PubMed index it is available regarding the empagliflozin. Comparing with other gliflozin, the EMPA, even though it started late, and the evidence, the multiple evidence, including the evidence regarding the sleep apnea also, it has been used. So that much amount of evidence, and as well as in fatty liver also, the empagliflozin has been tried. So in addition to the diabetic control, empagliflozin has extensively studied in various human diseases. And subsequently, the FDA approved was DEPA was 14, and subsequently the CANA and EMPA. So in India also, it subsequently launched, almost 5-6 years experience currently we have. So basically, the more and more number of SGLT2 receptors are expressed in the proximal tubule. So the predominant site of action of SGLT2 is the proximal tubule, 90%. Remaining 10% may be acting through the collecting duct or the distal part of the tubule. And it reduces the glucose reabsorptions and leading to the renal glucose excretions by osmotic diuresis. And this is various the pleiotropic mechanisms of actions of SGLT2 inhibitors overall. And so the predominant effect may be the cardiovascular benefit or other effect by reducing the blood pressure is by increasing the sodium excretions, and it reduces the fluid overload, and it reduces the arterial blood pressure. Hence, it reduces the cardiac failure. And similarly, by intravascular effect, it reduces the arterial stiffness, and again, it causes reductions in the blood pressure. By the intrarenal effect, the predominant effect in the afferent arteriole, it reduces the intraglomerular hypertension, and subsequently it reduces the albuminuria. So this is the most predominant mechanism of actions of SGLT2 currently available, and it is well studied across all gliflozins in the market. And it also has availability regarding the direct cardiac effect. Predominantly, they are all in vitro studies, anti-inflammatory, and it decreases oxidative stress, and it decreases apoptosis and mitochondrial dysfunctions. So the recent mechanisms what described how it improved the cardiovascular benefit is the sodium hydrogen exchange that inhibits the sodium hydrogen exchange inhibition. This is the recent proposed mechanism of the consistent cardiac beneficial effect of these various gliflozins. And this is again the summary of the slides. So it reduces the blood pressure by, it also has weight loss. The mean weight loss may be around 3 kg, but some people, they may have the significant or severe weight loss up to 5 to 10 kg. And again, it reduces the glucose, and in obese individual, it is one of the very good drug In addition to the cardiovascular, they have the pleiotropic benefits like arthritis. So by doing the hyperuricemia, by uric effect, it reduces the uric acid level, so it improves the arthritis also. And by hemodynamically, it produces the osmotic diuresis as well as the natriuresis. It reduces the arterial stiffness and improves the endothelial functions. As already told that it has inhibition of the sodium hydrogen exchange. That is one of the common mechanisms currently described by the beneficial effect of these SGLT2 inhibitors. And some amount of hyperketonemia also is being produced. And it has other endocrine beneficial effect, like it decreases the sympathetic tone, and some amount of counter-regulatory hormone increase like glucagon, and it improves the beta cell functions. And this is one of the paper from diabetology. It can have better than loop diuretics, because what loop diuretics will do, the intravascular volume contractions, whereas SGLT2 inhibitors affect predominantly the interstitial volume. So it doesn't produce hypotension much comparing with the loop diuretics. So the mechanisms is entirely different, and it is better than the loop diuretics that was being availability. And the postulated mechanisms in multiple mechanisms have been postulated. One of the mechanisms is the increase in the beta hydroxybutyric acid. Even though it is not in the extent of like what we see in diabetic ketoacidosis. Diabetic ketoacidosis, the beta hydroxybutyrate will be more than thousands. And in SGLT2 inhibitors, the beta hydroxy levels will be increased around 10 to 20 or like that. So the minimal increase in the beta hydroxybutyrate, it is beneficial to the heart by improving the cardiac fuel metabolisms, and it improves the myocardial contractility. It was one of the proposed hypothesis how it beneficial to the heart. And this is the comparisons between the EMPA, DEPA, and canagliflozin. So you can see that the dosage range from 10 to 25 in EMPA, DEPA was 5 to 10, and cana 100 to 300. And in India, most commonly the 100 is useful. And all are long-acting drugs. Only the remogliflozin, it is a short-acting. It has to be given twice daily, whereas all the empagliflozin, they are the long-acting drugs. And the peak plasma concentration administered comparable, and eliminations is hepatic and renal. The selectivity is difference between EMPA, DEPA, and cana. So there may be the difference between this the molecule based on the selectivity over SGLT2 as well as the 1. That is the difference. And so far the comparator between all the three molecules, the EMPA scores over regarding the evidences and literatures available in the regarding the heart failure, CV death, as well as the cardiorenal outcome. Cardiorenal outcome, the declared TIMI has some edge comparing with the empagliflozin, but comparing the cardiac, the EMPA scores over comparing with the other molecules. And it has been used almost along with all the agents. And it is a monotherapy, as well as in additions to the metformin, in additions to the pioglitazone, sulfonylurea, along with the insulin. The beauty of EMPA is it doesn't cause hypoglycemia. It is an insulin independent effect. Hence, it can be used along with any of the agents. And in addition to the insulin, it produces a decrease in the insulin requirement. So that is a beneficial effect. The mean HbA1c reductions by gliflozin alone around 0.7 to 0.9%, but many of the times it has been used in combination. So whenever you give a combination therapy, HbA1c reductions is far better comparing with using the monotherapy. So the combination therapy always better because it targets the multiple pathway instead of the single pathways that is using in the monotherapy. And so there is a significant difference in the weight comparing with other agents. And you can see that the mean average weight reductions comparing with the other agents. You can see that around 2 to 3 kg weight loss is seen in almost all the studies comparing with the other agents. And in some populations, it may have significant weight loss, as already I have described. And similarly, there is a reductions in the systolic blood pressure, and we may expect up to around 2.5 to 3 millimeter mercury reductions in the systolic blood pressure in the empagliflozin arm, comparing with the placebo or comparing with the other agents. And the ambulatory blood pressure monitoring study with the EMPA in people with diabetes and hypertension, there is a almost the level where maintaining almost similar to the physiological level and doesn't cause much hypotension effect in ambulatory blood pressure monitoring. Even though it reduces the systolic blood pressure, it maintaining the sympathetic tone. Hence, it doesn't cause any hypoglycemia. There is a nocturnal dip that is a physiological phenomena, and it doesn't produce much lower the blood pressure. And similarly, that is a 12-week study in patients with hourly monitoring of the diastolic blood pressure. Again, the lowest value is around 65 millimeter of mercury, and it doesn't cause, even though it is a better than placebo, it is reducing the blood pressure. It doesn't cause the hypotensions by this ambulatory blood pressure monitoring. And hence, by summary, it has a beneficial effect in the glucose control by improving the HbA1c, as well as it has reductions in the body weight, as well as it has reductions in the systolic blood pressure. And it is the comparative between the metformin, otherwise add-on the sulfonylureas or add-on DPP-4 inhibitor. So it has been studied extensively along with the existing all the oral as well as the injectable formulations of the diabetic therapy. And the safety and tolerability data. Initially, when this molecule introduced in the India, there was a fear that it may cause severe infections in the form of urinary tract infections. However, comparing the Western data, the Indian data, they have less incidence of infections. However, better not to use in presence of recurrent UTI or pyelonephritis or recurrent belanoposthitis in male populations, these type of agents. Otherwise, if many of the populations, they tolerate well, and there is no significant serious adverse effect that warrants the discontinuation of therapy comparing with placebo as well as Impartin. And there is a no dose dependent phenomena. Almost the side effect are the molecule specific rather than the dose specific. So by any patients developing side effect with the 25, it is a molecule related side effect rather than the dose related side effect. Hence, we have to serious adverse effect if develops recurrent UTI, then better to stop rather than reducing the dosage alone. And this is the landmark study. It changed the entire perspectives regarding the gliflozin, the EMPA outcome. Even though it has published almost 4 years back, it will be quoted throughout the lifetime. That much amount of the significant benefits it causes in almost in all the populations. Coming to the EMPA outcome summary alone, just I have highlighted, and you can see that there is a incidence or worsening of the nephropathy. It is less with EMPA comparing with placebo. You can see that hazard ratio of 0.61, and similarly the progression to macroalbuminuria also less with this empagliflozin, and the composite renal outcome also less comparing with placebo. So comparing almost the progression to the albuminuria and progression to the chronic kidney disease also less by improving the tubuloglomerular feedback of these EMPA molecules by acting in the afferent arteriole. So the patients with the type 2 diabetes with the high CV risk, EMPA given in addition to standard of care, it reduces the heart failure hospitalizations as well as it reduces the CV death with consistent benefit observed in people with or without heart failure at baseline. Even the Kaplan-Meier curve separates very early at beginning of the therapy alone. And so the separate yearly separation of the cumulative incidence curve, everyone will be very well aware. And even within immediately after the randomizations, the benefits became apparent, and the heart failure rate stabilized as number of patients with events increased over the time period. And so the how yearly after the treatment initiations are the CV benefits of EMPA apparent. It is a post hoc analysis presented in the ADA 2020, and you can see that At day 17 itself, it was reached, the treatment initiations and the CV benefit. So no need to wait. Some of the molecules we have to wait for a period of 3 months for the pharmaco kinetics effect start appearing. Whereas in empagliflozin, even at day 17 and day 27 for CV death, it has noted. So that much amount of the earlier benefit has been noted in the post hoc analysis, and the benefit on CV death reached significance for the first time at the period of 60 days. So you can see that as much as early we initiate the therapy, the beneficial effect is started very early, and we can prevent the hospitalizations for heart failure in by using these agents. And this is another study, Emprise study, that is a empagliflozin comparative effectiveness and safety study. And you can see that the heart failure hospitalizations rate and myocardial infarctions rate and ischemic and hemorrhagic rate. So the heart failure has a very, very significant beneficial effect in the Emprise arm comparing with the placebo arm. Again, it was again published in the 2020 ADA conferences. So the CV safety trials are being conducted for each compound within the newer classes. But now recently the ADA has been relaxed some of the CV safety data. But so far in the available, almost from starting 2013, after this the rosiglitazone's adopt study, there is a more and more cardiac failure and CV. It became mandatory at around 2013, and subsequently the sitagliptin and almost all the drugs whatever available, they came with the CV safety data. So whatever the anti-diabetic drugs currently available in the market, even comparing with the GLP-1 receptor analogs, the gliflozin and particularly the empagliflozin has scores over the CV safety data comparing with the other agents. And this is the comparisons between other like canagliflozins and the GLP-1 analogs like dulaglutides and albiglutides, as well as the semaglutides. And recently the ertugliflozin CVOT outcome was out, but it is comparing with other gliflozin, it doesn't have much significant beneficial effect. So the summarizing the SGLT inhibitors beneficial mechanisms, that is a multifactorial by reductions in the blood pressure, by reductions in the urinary albuminuria, and improvement of the glucose level, as well as reductions in the uric acid level, and reducing the oxidative stress and weight loss, and stabilizing the sympathetic overactivity tone. So it has a beneficial effect, and it gives the multiple beneficial effect. And this is the ADA EASD consensus report. You can see that even prior to metformin, whenever there is a high risk group or high risk atherosclerotic cardiovascular disease patients, we can use it gliflozin as a first line. This is the recommendations from the ADA and EASD consensus statements. So with that, I am concluding. Thank you for your kind attention.
Thank you, Dr. Sridhar, Dr. Thomas, for your excellent presentation. There is a question for Dr. Sridhar. So, do you think from the audience, so according to you, empagliflozin can be treated as par with metformin in diabetic patients? When means if we start early, if we initiate early?
So the recommendations is from the high risk atherosclerotic cardiovascular disease, not as a first line therapy or in a pre-diabetic patients, it is not recommended. But other comorbidities is there, like morbid obesity or hypertension, unable to reduce weight, and the fatty liver or obstructive sleep apnea. So in such situations, based on the other comorbidities, we can initiate. But even though there is a no guidelines, but case by case base, we can initiate the gliflozin as yearly. But the guidelines recommendations is for only the high risk atherosclerotic cardiovascular disease, like the multiple risk factor scoring systems are available, like family history or dyslipidemia, or any prior events, CV events, or any stroke, or like that patients, they recommended the first line. So other based on the other risk factors at the early onset or first line therapy, we need to wait for more data.
Okay, Dr. Thomas, there is a question. Does empagliflozin can be used in multiple CV risk factor patient?
Sorry, I didn't get the question. Can you repeat that to me?
Yes, have to repeat, sir? Okay. There is a question from audience that does empagliflozin can be used in multiple CV risk factor patient?
Well, I think if you're talking about heart failure treatment, I think if you're talking of preventing heart failure, I think it should be a drug which the diabetologist probably would want to look at, But honestly, if you're talking about those with multiple risk factors, probably, I mean, that's not something that the cardiologist usually would be treating.
Sir, multiple CV risk factor patient, cardiovascular risk factor patients.
Yeah, so that's what I'm saying. I mean, I would that wouldn't be a drug that would be first in the line that I would be looking at. If it's a dyslipidemic patient, I would treat him with statins. If he's a hypertensive, I would treat him with antihypertensive. But I don't think in a patient with that sort of a risk profile, I would start him with EMPA. No.
Okay. Yeah, thank you. There is no more questions, so we're concluding the session, sir. Okay. Thank you, Dr. Sridhar, Dr. Thomas, for your wonderful presentation and sharing your valuable experiences. And on behalf of Lupin, we thank you both. Take care, and we'll see you in the future meetings. Thank you
so much. Thank you.
Thank you. Thank you. Thank you.